Hello and welcome to the MIMS Learning Clinical Update podcast, the podcast that brings you thought-provoking clinical education that you can fit into your busy life. My name is Dawn Liz Powell and I am medical editor at MIMS Learning. Today I will be speaking to Professor Lesley Kavi about postural tachycardia syndrome, or PoTS. Professor Kavi is a retired GP and chair of PoTS UK, a charity dedicated to supporting people with PoTS. Welcome to the podcast, Lesley.
Hello, Dawn, and thank you very much for inviting me to join you today.
So, GPs and other healthcare professionals are becoming more aware of PoTS, but it's still not that widely known. What is it?
Well, PoTS, in medical terms, was relatively recently defined and named, in fact, in 1993 in North America. And it's a syndrome and probably has a number of different causes and mechanisms. In all cases, however, there's an abnormal response to upright posture. When healthy people stand up, their blood immediately falls down into their abdominal cavity and limbs, but their blood vessels narrow immediately and the heart beats by an extra 10 to 20 beats per minute, and that squeezes the blood back up to the heart and brain. But in PoTS, the blood vessels don't constrict properly and blood pools in the abdominal cavity and in the dependent limbs. And you can actually see this in half of PoTS patients in their feet and hands. They go purple and puffy when they're standing still. To compensate for this, the heart rate increases excessively, and that's by more than 30 beats per minute in an adult, and extra adrenaline is released, presumably in an attempt to raise the blood pressure. The altered circulation and excess adrenaline cause many of the symptoms of PoTS.
Okay, so you were just sort of saying there that increased heart rate is a sign of PoTS, like increased heart rate on standing. But what are actually the symptoms? How would this manifest?
Well, affected patients often experience lots of different symptoms at the same time, and the key is that they're more prominent when they're upright. The commonest three symptoms are lightheadedness or pre-syncope, fatigue, and fast palpitations. But other symptoms include headaches, gut problems, chest pain, fainting, breathlessness, shakiness, sweating, visual greying or glare, cognitive dysfunction or brain fog, which is often the most disabling symptom in PoTS, poor sleep, and exercise intolerance. The symptoms can fluctuate quite a lot, and people can have really good days with minimal symptoms, but they can have other days where they can barely get out of bed, and this causes them a lot of difficulty in working, for example, or having access to benefits when they can't.
So you're mentioning there that PoTS has a whole range of symptoms that can fluctuate. And I think, is it right that PoTS is linked to hypermobility? Because I have hypermobility and I sort of sarcastically call it the gift that keeps on giving. So it sounds, PoTS is very similar to that. And so it is. So is it linked with hypermobility, and is it like the gift that keeps on giving?
Yes, about half of our charity membership have hypermobile joints. I mean, just in their own, it can be an advantage to have hypermobile joints. A lot of athletes, gymnasts, dancers, and so on are hypermobile. But some of these people have hypermobile Ehlers-Danlos syndrome or hypermobility spectrum disorder. And this is a multi-system inherited disorder. Affected patients have symptomatic hypermobile joints causing pain, dislocations, subluxations. And they can also have problems in other parts of their body, such as gut problems, bladder problems, skin problems. And of course, they have autonomic dysfunction, and that can either be PoTS or orthostatic hypotension. You tend to find it's more common in younger women, but it can affect any age group or sex. And it's also linked to other conditions, such as mast cell activation syndrome and some autoimmune conditions as well.
Okay, so you mentioned that PoTS is linked with hypermobility and maybe other conditions, or these conditions can makes somebody susceptible to PoTS? Because I think, is it right that PoTS can occur after a virus like glandular fever or, something like COVID even?
Yeah, I mean, the precise link between all of these conditions is not completely clear, and there's some research being done into this at the moment. It's common for PoTS to develop after a viral illness such as glandular fever or COVID-19 infection. And in fact, between about 7 and 14% of people with long COVID seem to have PoTS. And people who are predisposed with hypermobility are quite often seen to either develop symptoms for the first time or have an exacerbation after a viral infection.
Is there another thing that PoTS can be caused by deconditioning? So is it because if they've had the virus, they've got this hypermobility or whatever, and that's already predisposing them to PoTS, but then because they've been a virus, been laid low, they're not exercising and other things, and they're being deconditioned, is that another reason that could trigger the PoTS?
Exercise and deconditioning is quite a contentious issue in relation to PoTS. I think we're pretty clear that deconditioning in its own right doesn't actually cause PoTS. There's a lot of people out there who don't exercise at all, but they don't have PoTS necessarily. However, if somebody has developed PoTS, because their vasculature isn't returning the blood back up to the heart and brain, they rely quite heavily on their muscles to act as a muscle pump, almost like a second heart. And if your musculature has become deconditioned, you can't compensate as well. And so we tend to find that it exacerbates PoTS, but it doesn't seem to be the prime cause.
Okay, I suppose it's like there's all these different factors going on, and it's not one particular thing, it's just a combination of factors.
Yeah, that's right. I mean, there seem to be a lot of different factors that can go towards either triggering PoTS or, in people who have it already, to causing exacerbations.
Okay, so now focusing on what a GP should do or a GP might see. So patients come in and they're talking about they've had a faint or they've had something else go on. What would be a red flag or a sign, oh, this could be PoTS?
Well, I think GPs or other healthcare professionals should have a high index of suspicion for PoTS in people with these underlying or associated conditions that we've already discussed, such as hypermobile Ehlers-Danlos syndrome or long COVID, and also in CSF-ME, it's quite common. And certainly when I worked as a GP, I used to find it in people with very thick medical records in the days when we used paper notes, or in people who attended many medical appointments without a clear diagnosis, or they might have been told they had medically unexplained symptoms. And particularly, we've been talking about hypermobility, and particularly in the hypermobility population, which is so strongly linked with PoTS, they've often been under cardiology in the past with palpitations. They might have seen ENT with dizziness. They might have been under gastroenterology with irritable bowel syndrome or functional gut problems, in inverted commas. And they've often been given a label of anxiety to account for their symptoms. And in addition, if people are describing symptoms that they find are much worse when they're in the upright position and when they've got sort of multiple symptoms all at once, then that's another situation when I would be thinking about PoTS.
Okay, I think just interesting there you're talking about anxiety, and PoTS like ME, chronic fatigue syndrome, and long COVID, to be honest, is notorious for being one that's dismissed as, oh, it's all in your head. I think, though, the problem is then you get the overlap. You get people who have got health anxiety and they're coming with these situations and they have got health anxiety and that's their predominant issue. How can a doctor go, this might actually be something, rather than, oh, this is actually health anxiety? That must be actually quite tricky for a GP to determine.
Yeah, I mean, I think that very often patients know when they're feeling anxious and when they're not feeling anxious. And even in PoTS, they can often sort of tease out situations when they're having psychological anxiety or they're having symptoms that you can experience in anxiety, but they're not related to an anxiety generating problem.
In terms of determining whether something is PoTS or a health anxiety issue, I think one of the problems might be that the patient themselves kind of doubts themselves and doesn't really believe what they're experiencing is a physical thing, that they themselves might think, oh, it's all in their head. How does the GP then sort of support the patient to try and determine, no, this is something that's actually happening?
Well, first of all, about 50% of patients with PoTS are told that their physical symptoms are all in their head. But one of the good things about PoTS is that there's a test for it. You can do a stand test, and that can show or help to show that there's a physical basis for it. In addition, that there's the cluster of symptoms that can help you point towards PoTS, and you can explain this to your patients. I think what's very difficult is when patients have, for example, both PoTS and they have anxiety. And, very often people are healthy, young, fit people, and then almost overnight they can be rendered very unwell with PoTS, and that takes a lot of adjusting to. And in addition, a lot of the symptoms of PoTS, such as, for example, chest pain and palpitations, are really very scary symptoms. And so sometimes, even if you've established that the person has PoTS, it can be that having psychological support to help them adjust to, the big changes in their life, or to cope with these really very scary symptoms, can be helpful. But I think you have to be quite thoughtful in how you explain that to your patient if you feel that you would like to refer them to psychology, because often they've been mislabeled with only having anxiety for a very long time and beforehand.
In the GP surgery, the GP's going, right, I think this might be PoTS. What's the next step? What do they refer them on somewhere?
I don't think you have to refer them at the outset. If a GP is suspicious that someone has PoTS, they can do a 10-minute stand test. When I used to do that as a GP, I would usually rebook my patient in for a separate 20-minute appointment. I would lie the patient flat for a few minutes until they were settled, and I would attach them to a battery operated SFIG so I can monitor both their heart rate and blood pressure. And then you would do their heart rate and blood pressure when they're lying flat and rested, and then you stand them up. I would usually stand them up against a wall or in front of a bed or a chair, because very occasionally patients will faint when you're doing a stand test, and I would make sure that there's no sharp objects in their vicinity. So you would then, once you stand the patient up, you would do an immediate heart rate and blood pressure recording, and then do it every 1 to 2 minutes throughout 10 minutes, unless you have to stop the test before then. And I would usually take an extra recording if the patient starts to become particularly symptomatic, and I would record the heart rate and blood pressure in relation to the symptoms. The definition of PoTS is a persistent increase in heart rate of 30 beats per minute on standing and 40 in children. And this has to be associated with symptoms of PoTS. Patients should have been experiencing these symptoms for at least 3 months. As part of the definition, blood pressure does not drop in PoTS, but it can be quite unstable. However, some people with PoTS do go on and develop a vasovagal episode. Can I just highlight that the persistent issue is quite important? If you're doing a stand test on someone, head rush is quite common. It's also called initial orthostatic hypotension. And in a healthy person, they will usually drop their blood pressure briefly when they stand up, and then they have a slight increase in their heart rate to compensate. And this is perfectly normal finding, but it usually settles by about 45 seconds. It's not PoTS, but it sometimes gets confused with PoTS.
Is there someone they could be referred to for specialist advice, or is it something you can be managed in primary care?
If you're confident about the diagnosis, you can initiate management for PoTS in primary care, usually with lifestyle changes in the first instance. And there's a lot of information about that on the PoTS UK website. It tells people what PoTS is in non-medical terminology, and it describes how patients can manage their symptoms. And the sort of lifestyle things that I'm talking about are things like a high fluid intake, high salt intake if it's not contraindicated, dietary measures, compression clothing, in some people exercise and pacing, and also postural manoeuvres that can help patients to either faint or to have pre-syncope episodes. We've got social media through the charity, which is very heavily moderated on a daily basis by the charity, which some people find helpful. And there's also a group for parents of children, which is run separate to the charity, but a lot of parents find that useful. And our charity also runs virtual peer support groups. So they're the facilitators are patients who've been trained by our charity, and they have topic-based meetings. And some of these sessions are for newly diagnosed patients. You know, if the GP is initiating management, then some of these facilities might be helpful to them.
So just thinking about lifestyle modifications, things like, for example, drinking lots of fluid, lots of water and non-caffeinated drinks. Is there an element, though, that of managing the patient's expectations about sort of saying like this will help you to function, but it's not going to be a cure. You're not going to feel marvelous, but it'll help you feel better.
Yeah, I mean, some people with PoTS do improve even with no treatments. They will just improve with time. That's probably a minority. But some people will continue to have long-term symptoms. And it's often a case of doing this one thing will improve you 1 or 2%, doing something else will give you 5% improvement, and so on. And so it can be very, very difficult to even adopt these lifestyles. They sounded simple, but patients are having to do a lot of different things at once, and they're having to kind of think about it all day long. For example, the fluid intake can be difficult because a lot of people have gut problems and they can't have a large fluid intake, so they have to do little and often. They sometimes have to make dietary changes. Wearing compression can be difficult to get on, and it makes people really dizzy when they put it on, and it can cause them to overheat, which can be counterproductive. So I think it's true that, you know, some people can go on having symptoms, and I think you have to explain to them how difficult and it can be, and it can take quite a lot of practice and sort of getting into a routine to be able to adopt all these lifestyle changes at once.
You were talking about exercise intolerance. Are there any exercises that would be good for somebody who's got exercise intolerance?
Yeah, I mean, in the perfect world, if somebody finds that they're exercise intolerant, in other words, just doing even a small amount of exercise can leave them wiped out for hours or days afterwards, then it is really useful if they can have input from a specialist exercise physiologist or physiotherapist who really understands the condition. But unfortunately, people do have a lot of difficulty in accessing that, and particularly people, for example, with CSFME and long COVID, they can be especially exercise intolerant. But where people feel ready to exercise and it's deemed appropriate, then doing exercise in a horizontal position is a good starting point. It often has to be started at an incredibly low level and then escalated when the patients are ready to, and at a very slow and steady pace. So the sort of exercises are, for example, Pilates is quite useful to do. Some people find recumbent exercise bikes or rowing machines are quite useful as well. Swimming's often recommended, but one of the problems with swimming is after the patients have exercised, coming out the water and going into a hot changing room and standing up and getting dressed can really make them very, very symptomatic. So after exercise, it's important to cool down and rest, often in a horizontal position until the heart stopped racing. Particularly in the swimming environment, just get everything ready so that you can leave very quickly and go home and not have to stand for too long in a hot environment before you leave.
You just said there about Pilates. If somebody's hypermobile, would that actually be contraindicated almost because they could do damage because they're stretching themselves in a way that perhaps isn't good for their joints?
Yeah, I mean, what you've just mentioned also applies to yoga. Some people find yoga is very beneficial to them in PoTS and in hypermobility, but really you want to try and find an instructor who has some knowledge. And because of the link, because of the link with PoTS and hypermobility, and also the fact that a lot of people turn to yoga and to Pilates for help, increasingly the instructors are becoming aware of it and they know how to adapt their exercises for patients in these groups.
What about medical treatments? Is it midodrine is actually been shown to be effective?
Yeah, there are a number of drugs that have been used in PoTS. We tend to use them when people haven't responded to lifestyle changes over perhaps a 3-month period, although that period might be shortened if the patients are very unwell. There are a number of drugs that have been used, and there have been some studies. We would like to see a lot more larger sort of multi-centre studies involving medication and other aspects of PoTS. I mean, some of the commoner ones are midodrine, as you quite rightly say, and ivabradine is another one that tends to get used quite commonly. Fludrocortisone is another one. Pyridostigmine is another one. And then beta blockers, there is some evidence for the use of beta blockers, but we tend to find that patients need really very, very small doses of beta blockers, almost pediatric doses, because if they go for a higher dose, it tends to worsen their symptoms. They're all unlicensed, unfortunately, for PoTS, but some GPs will prescribe them because they're familiar with using the drugs. And as long as you sort of follow the GMC guidelines for prescribing unlicensed drugs, then you should be able to prescribe some of them. But some of the more unusual drugs are sometimes prescribed with a shared care agreement with the consultant.
Okay. You were talking before about how some people get better without any sort of treatment and other people will require some sort of medical treatment because they haven't responded to lifestyle measures. What overall is the prognosis with PoTS? Is it a lifelong condition?
In truth, we don't fully know. There haven't really been any very large population studies looking at large numbers of patients over a long period of time. But there's quite a lot of experience amongst healthcare professionals and patients regarding this issue. Some people do seem to get better quite quickly after they might have had a viral illness trigger and then they have PoTS for a while and then it just seems to resolve. But a lot of people do have persistent symptoms, and particularly the people who have more of an inherited basis for it, such as the hypermobility group, then they're likely to have long-term symptoms that can wax and wane. Sometimes they can go through periods for quite a long time where they're feeling better, and then they'll go through shorter prolonged periods where their symptoms are significantly worse.
So say somebody's been diagnosed with PoTS and they're perhaps not responding to treatment. When would be an indication that this perhaps isn't PoTS and it actually might be a sign of something life-threateningly wrong or something?
I mean, hopefully you would pick that up in the workup at the beginning before you've made your diagnosis. So there are some consensus guidelines out there, and also we've posted information on our website about how to diagnose PoTS. And there are a number of tests, blood tests that you should be considering. They're not standardized. It really depends on taking a history from the patient and deciding which ones are the most appropriate. But you might be looking at things like, for example, a full blood count, thyroid function, because hyperthyroidism can mimic PoTS. You would be thinking about maybe doing a morning cortisol level to rule out Addison's, because that can cause quite similar symptoms. And then again, depending on the patient's symptoms, you would almost always want to do an ECG because they've often got chest pain and palpitations. And then a lot of patients have an echo, and again, that would pick up some cardiac problems. I think particularly in the setting of long COVID, it's very, very difficult because obviously in COVID, you would have been prone to cardiac issues due to COVID, and then the POTS symptoms are quite like COVID. So I think you have to be particularly cautious in this situation. I think you're probably more likely to go down the cardiac investigation route first.
You were saying that about an ECG, and one of the big problems with an ECG, if it's like just a 12-lead ECG, is if there's nothing happening at the time, it's not going to pick it up. So you would need to have longer investigations, like a Holter monitor or even longer to try and pick something up.
Yeah, you're absolutely right. So an ECG doesn't diagnose POTS. What an ECG does is help you to exclude other problems. And yes, having like a Holter monitor, again, can be useful to rule out other problems. It can be a pointer towards POTS. So if you see that a person during a prolonged ECG monitoring is having recurrent sinus tachycardias, and again, I would usually recommend that the patient describes what they're doing at the time if they're symptomatic, and sometimes you can tie that in. And you might see that they're usually upright when they get these cardias, or and they might well be symptomatic with palpitations during that period of time as well. So a 24-hour or another prolonged ECG monitor might point you in the direction of POTS, but it won't diagnose it. You either need a stand test or a tilt test, plus the correct symptomatology to diagnose it.
You've just mentioned a tilt test. Could you say what that is?
Sure. So a tilt test has to be done in a laboratory sort of hospital setting. There's a device which is a table that has a foot plate on it, and it can be tilted head up and head down. And for POTS, it's usually tilted head up 70 degrees, and then the foot plate stops the patient falling off the bed when it's tilted upright. Associated with this bed, the hospital usually has some form of beat-to-beat monitoring. So in a way, it's better than a stand test because you can actually monitor the patient's heart rate and blood pressure. Sometimes there's facilities to measure other things, such as oxygen levels while the patient is on the tilt table. And they get a printout. So it's quite useful sometimes where the stand test doesn't really give you a clear diagnosis. Sometimes it's necessary to refer people on to the hospital where they can have access to a tilt table for further information.
Okay, so POTS Awareness Day that POTS UK runs is on the 25th of October. What are the goals of this day and how can healthcare professionals get involved?
So POTS Awareness Day is primarily about raising awareness of POTS amongst generally the community and also amongst healthcare professionals. And a sort of byproduct of that is that it's also an opportunity for people to fundraise for our charity, because sometimes holding fundraising events in itself raises awareness. What can healthcare professionals do? I think if they'd like to sign up to our healthcare professionals newsletter via the website, it's free. We only send out about 2 or 3 letters a year. And in addition to sort of highlighting what's going on in Awareness Month, people will also get research updates, news about educational events, quite often hold them for GPs, often online, support for your, the GP's patients, and also news about the charity. In terms of actually getting involved, healthcare professionals could post one of our leaflets. We've got downloadable leaflets in their waiting room, or they could post a link to them on their social media. We've got a leaflet for GPs, which is just 1 page long on the website, and they could share that with colleagues. Last year, we had over 80 buildings in the UK light up purple for POTS. So if either the place that you work or a nearby hospital or university or other building tends to be lit up, you could ask them if they would light up purple to raise awareness for POTS.
Thank you so much for speaking with me today, Professor Kavi. Don't forget that you can claim CPD credits for listening to this podcast, so be sure to go to mimslearning.co.uk to download your certificate. We will also, on the module version of this podcast, be putting links to all of the resources that Professor Kavi mentioned and for further reading. Do join us next week where we'll be having a studio discussion.